Welcome back, everyone, to the Down Syndrome Center of Western Pennsylvania podcast. I'm your host, Dr. Kishore Velody. Today we are joined by Dr. Sangeeta Chakravorty, who is our pediatric sleep medicine specialist at the Children's Hospital of Pittsburgh of UPMC. Dr. Chakravorty, it's great to have you join us today. Could we start off with hearing a little bit about your training background?
Sure. I trained as a neurologist in Buffalo, New York. My training background was actually in adult neurology. And then I did a subspecialty training fellowship in sleep disorders medicine at Emory University in Atlanta. I've been in Pittsburgh for the last 12 years, but I've been specifically interested in pediatric sleep since the last 7 years. That's how long I've been here at Children's.
Great. Well, thanks again for joining us on this podcast. As you might imagine, we're hoping you can give us some information on sleep apnea and sleep studies today. Sleep apnea is known to be extremely common in kids with Down syndrome, so this information will be very useful to our families. But before we get too far ahead, can you give us some background on what sleep apnea is?
Sleep apnea is the process by which breathing pauses during sleep. Apnea means absence of breath going in or out. The airway closes up during sleep. Because during that time, our muscles are particularly vulnerable to being more limp and more relaxed. And gravity narrows down the air passages so that if there is collapse of the upper airway, which is like a muscular tube, then air can neither enter nor exit. If that happens, that's called an apnea. Usually the brain compensates and awakens the individual after an apneic pause so that there is breathing restored, which is the recovery phase after apnea. For example, if you sigh and you hold your breath, that's considered an apnea. But that's normal. If this happens during sleep, more often than we like, then we term it pathological. There are several types of apnea as well. So one's called obstructive apnea, where the air passage really narrows down and closes up, and the lungs and the heart sense that. So it increases the respiratory muscle effort to breathe. And that's termed obstruction. And there's another type of apnea called a central apnea, where the airway might close up or narrow down, but there is no stimulus to breathe, and the abdomen and the chest stay calm and quiet for a few seconds until the brain triggers a recovery breath.
Thanks for that overview. Since obstructive sleep apnea is so much more common in children with Down syndrome, I'd like to spend the remainder of the podcast talking about that. Can you give our families some idea of what symptoms may be present in a child with sleep apnea?
Sure. If you hear your child snore at night habitually, more than 2 to 3 times per week, the snoring could be soft or loud. That's a sign that your child is potentially at risk for obstructive sleep apnea. Not everyone who snores has obstructive apnea, but they might develop it at a later time. If your child has already developed obstructive apnea, then the snoring might include a crescendo pattern. By that I mean it might get louder over time, and there may actually be pauses in the breathing that you might hear. For example, it might sound like this. I don't know if you can get that, but that was an obstructive pause followed by a recovery breath and a long expiration. If you hear that happen periodically at night, that's a sign that your child might have obstructive apnea. During the daytime, the child might be more irritable, might be a little cranky. The child might have nasal congestion. The child might have mouth breathing that you could observe during the day or at nighttime. He might wake up with a dry mouth. Some children who have obstructive apnea may have night sweats, and some children might also lose control of their bladder at nighttime. The child could also be very restless and toss and turn, moan and groan at times. Sometimes you might have nighttime coughing that might occur after a lot of snores. Those are some of the signs that we encounter commonly in clinic.
Thanks. So if a parent notices these issues, I would typically recommend a sleep study. However, some families wonder if sleep apnea is really that important to diagnose and treat. What are the possible complications of untreated sleep apnea?
If sleep apnea is untreated, it can definitely impair the quality of the child's sleep. It might impact the quantity of the child's sleep. And sleep deprivation in children can be a trigger for learning, memory, and mood kind of problems during the daytime. It can also make the child cranky and irritable. It might affect how they perform at school, and it might make them tired during the day. Some children, as opposed to getting tired, may develop hyperactivity and inattention and may mimic ADHD type symptoms during the daytime. So those are the more immediate short-term effects. Over the long term, untreated obstructive sleep apnea can lead to cardiorespiratory problems. In adults, it's been shown to be a risk factor for hypertension and heart disease. It has also been associated with obesity and metabolic syndrome in some individuals. And in very rare cases, it can be associated with increased pressure in the pulmonary blood vessels called pulmonary hypertension. In very young children, untreated obstructive sleep apnea can affect their appetite, can affect their growth, can affect how their facial skull features develop. And that's one of the reasons why we like to recognize it and treat it early.
Well, those are obviously issues that a parent would want to avoid for their child if possible. What should a parent do next if they notice the signs of sleep apnea that you just told us about?
If you suspect that your child is not breathing correctly, do bring it to the attention of your primary pediatrician or to a specialist medical professional whom you encounter and explain your suspicions to them. They will ask you some questions, including obtaining a sleep history. And getting an accurate history is one part of making the diagnosis. The second part is some form of clinical testing to confirm the diagnosis. This could be of two types. You could have an X-ray, for example, of the lateral neck area and look at a soft tissue enlargement of the adenoids and tonsils. These are lymph tissues that sit at the entrance to the mouth, at the back of the throat, and they commonly enlarge in children between the ages of 2 and 8. Even though the size may not appear very large on clinical examination, or if you just look at it with the naked eye, it can have functional impact because of the size when the child is sleeping. The child's clinical symptoms will give you some diagnosis. Another way to test is to perform an overnight sleep study, which is considered the gold standard for testing based on the recommendations of the American Academy of Pediatrics.
Great. Well, Sangeeta, as you know, the American Academy of Pediatrics updated the healthcare guidelines for children with Down syndrome in 2011. And in that update, they recommended that all children with Down syndrome have an overnight sleep study by the age of 4 years, because sleep apnea is just so common in this population. Why is that?
Down syndrome represents a special population of children who have certain predictable craniofacial features that predispose them for a higher incidence of obstructive sleep apnea compared with the general population. Their stature, their slightly flatter noses, the size of the tongue, as well as their low tone, all lead to a higher risk of sleep apnea. And there are clear guidelines because the sooner you diagnose and treat this, the better their long-term impact and outcome in terms of learning, school performance, as well as eventual facial development. And that's one of the reasons why these guidelines were included.
Okay. So with these new guidelines, a lot more of our families are going to be bringing their children for sleep studies. Could you please walk us through the process from scheduling the sleep study to the study itself?
When a family makes an appointment to have their child undergo a sleep test, we'd like them to understand all the steps that are involved. So invariably, you will schedule a study overnight, which means you bring the child one evening after dinner, bring a change of clothes for the next night. You are usually assigned a private bedroom with an attached bathroom. There is a bed for the child and some sleeping arrangement for the accompanying parent who comes in with the child. Essentially, we want to replicate the atmosphere of sleep that the child has at home. So you can bring their favorite toy, you can bring their blanket, you can bring a comfort object that the child usually sleeps with. Usually we want the child to have had their dinner and to be comfortable and ready to go to bed when they come to the lab. In addition to the bedroom atmosphere, there's a technician who is going to assist you through the night. The technologist is going to place certain sensors on the child, on their body, which do not involve any needles, which do not involve causing any injury or pain, but they are stuck to the child and have to last overnight. So some labs use a form of electric paste to hold the electrodes and sensors in place. Some labs use a form of glue that has to be dried and is held with tape. What do we measure during the sleep study? We measure the child's brain waves, we measure their eye movements, we look at their heart rate, their blood pressure, we look at their oxygen levels, we look at their carbon dioxide levels, we look at how the air is entering and leaving the nose, we measure snoring. We also look at how their chest wall and their belly move, and these are measured using wires, using some plastic tubes which are called cannulae. For example, a plastic tube might slide under the child's nose to measure the air going in and out. There will be an elastic belt that goes around the child's chest and belly. There may be some wires on their legs because we look at their leg movements also. And these wires have to last the whole night. So we want them to be stuck to the child pretty securely. If they move or if the wire comes loose, you can buzz and request the technician to come and fix the problem. Or if the child needs to get up to use the restroom or something, the technician can assist the parent. And in this manner, the child sleeps for at least 7 to 8 hours. Then they get woken up the next morning and the technician will remove all the equipment and you can leave. Your child is free to go home. So that's what happens during an overnight sleep study. The term polysomnogram is sometimes used. It's abbreviated as PSG, and it simply means that we're measuring a bunch of signals during sleep.
Well, thanks for walking us through that process. I'll be honest with you, it sounds like there are quite a lot of leads and wires, and children with Down syndrome, they tend to have some pretty significant facial sensitivities. So how in the world do you get them to keep all those wires in place?
We are very patient with the children. The technicians are really very skilled. We have one technician to one child and one family assigned most of the time when a child with Down syndrome comes in for a sleep study. So you have their undivided attention. We really do a good job trying to secure things to the child's face with their permission, with tape, with latex-free tape if necessary. We try and use other types of softer material to make it as comfortable as possible for the child and the family. Sometimes if the cannula slips or the sensors come loose, the technician will re-enter the room with the parent's permission to attach them again. And we try and get as accurate a signal as possible and do our best.
That's good to know. Now, besides the technicians who are specially trained to work with the children, are there any other differences in sleep studies that are done, let's say, at a children's hospital as opposed to a community hospital?
Yes, there certainly are some differences. In general, between the ages of 0 to 12 years, there are certain specific pediatric guidelines and criteria which differ slightly from adult criteria. And our pediatric sleep lab really does a good job of doing and performing the tests in concordance with these guidelines from the American Academy of Sleep Medicine. One of the fundamental differences between adult labs and pediatric specialty labs is that adult labs do not require overnight continuous carbon dioxide monitoring, whereas pediatric specialty labs are mandated to do so. That provides very valuable information that is otherwise missed in some adult situations, because children have a higher tendency to retain CO2, and unless we measure that, the test is not thorough or complete.
Thanks. I think that's a point that a lot of families are not aware of. There really is a difference between getting a sleep study done at Children's versus getting it done at another place. Well, after a sleep study is completed and all that information is analyzed, we usually get a report from your sleep lab in a couple of weeks that tells us if there is significant sleep apnea. What are typically the next steps based on those findings?
That's a good question, but it depends on the results of the study. Obstructive sleep apnea can be classified based on the severity into mild, moderate, or severe. And based on what has happened to the child before, what the other comorbidities are, which means what are the other medical conditions that a child with Down syndrome may have in addition to obstructive sleep apnea, all of these determine the sort of treatment. In general, if it is very mild and there is simple snoring, we may tend to watch and wait for a few more months until apnea develops to treat. Sometimes when there is mild sleep apnea, which means there are breathing pauses, say between 1 time to 5 times per hour of sleep, which is the term that we use to calculate the index of severity. In that case, we may prefer that the child be evaluated by ear, nose, and throat surgery to take a look at the adenoids and tonsils. Sometimes a simple adenoidectomy and or a tonsillectomy, which means removal of these tissues, can be curative in a subgroup of children, but not always, especially if they have Down syndrome and have other issues. And if the child has severe sleep apnea, then we definitely prefer that a multidisciplinary team get involved, and that may include a lung specialist, may include an ENT surgeon to comprehensively assess the child and determine other forms of surgical treatment.
And are there any other options besides surgical options?
There is a form of non-surgical therapy which is available for treatment of obstructive sleep apnea. It's called CPAP, termed CPAP. That stands for Continuous Positive Airway Pressure. Effectively, through a mask and a machine that is connected to the mask, the machine acts like a blower and blows in room air which is slightly pressurized into the child's nose to help splint the air passage open. In this manner, there is no narrowing of the airway, and the continuous smooth flow of air supports breathing during sleep in such a manner that there is less awakening, less arousal, and the oxygen levels on the child are maintained at a stable value. This is sometimes challenging in children with Downs who cannot understand why they need to wear the apparatus. It is also challenging in some adults because it's a very commonly used treatment in adult obstructive sleep apnea, but we do successfully use this treatment in a large group of children, including those with trisomy 21, who do very well once they wear this apparatus through the night. Its non-surgical advantage is a great advantage, and I would encourage families to consider this option if they have exhausted surgical options.
Excellent. Well, thanks for that summary. That's actually all the time we have for our podcast today. I want to thank you, Dr. Chakravorty, for joining me today and sharing your expertise.
Thanks, Dr. Valodi. It's been my pleasure. I hope the families benefit from listening to some of this information.
I'm sure they will. Well, thanks again. And thanks as always to you, our listeners, for tuning in. Be sure to keep watching for our next podcast. Until then, bye-bye.